Well, hello, class. We're going to start our new lecture. I thought we could just do a recording of what's on my screen rather than having you look at my face. But anyway, you'll need to open up your file on psychotic disorders, um, the PowerPoint slide. So we'll get started here. It's a general overview and introduction to psychotic disorders. Psychotic disorders refers to that entire class of disorders that have to do with people mainly who suffer from schizophrenia or schizophreniform disorders. Um, Schizophrenia, of course, is the most famous of all the psychotic disorders and the most common. Um, for most of the history of mental health in the 20th and 21st century, schizophrenia has widely been believed to be the most serious of all mental illnesses, not just because of what it's associated with, but also just the experience of the sufferer. It is extremely frightening when someone can't tell the difference between fantasy and reality, and when what one sees is doubted by the rest of society in the form of delusions or hallucinations. So, this second slide here goes over the main symptoms diagnostically, but then also just what you'll observe as well, signs and symptoms of schizophrenia. So, first would be grossly disorganized speech and behavior. Second would be a strong functional decline. One thing to definitely be on the lookout for in terms of schizophrenia is that the first thing you'll usually see in people who are becoming actively symptomatic, and this is true for the more positive symptoms of schizophrenia, the so called type 1 symptoms, versus the negative symptoms of schizophrenia, the so called type 2 symptoms, is social withdrawal. So when people begin to withdraw a little bit from their everyday social interactions, when they begin to spend more time alone, when they stop grooming, showering, taking care of themselves, getting dressed every day, um, that's one of the first signs that someone may be beginning to have a psychotic episode. Most famously, schizophrenia is defined by hallucinations and delusions. As a reminder, a hallucination is when there is perception without sensation. That means that someone is perceiving something to be there, usually something that is along sensory lines, but there's actually no sensation taking place. It's a perception without sensation. Most people, when they're functioning normally, have roughly one-to-one correspondence between sensation and perception. That is, what it is that I can see, touch, smell, taste, or hear corresponds roughly to what it is that I perceive that I see. So, what I perceive that's there is also what I'm actually sensing is there. Whereas someone who has psychosis can have um, hallucinations that indicate that they're sensing something, but they're not actually sensing something. They just perceive it to be there. And the most common of the hallucinations is the auditory hallucination, particularly in the former subtype of schizophrenia known as paranoid schizophrenia. Visual hallucinations, that is, when you see something that's not there, is the second most common. And with tactile hallucinations, that is, when you feel something that actually isn't there, it's pretty common as well. But the one thing you really want to be on the lookout for is drug intoxication or drug withdrawal. So a lot of people, when they're coming off of a drug or when they're um, experiencing some of the active phases of a drug or the effects of a drug, will report that they sense things, or even though they're not actually sensing them, they just perceive or believe that, for example, bugs might be beneath their skin. They may have tingling sensations that are not actually real. Olfactory and gustatory hallucinations that have to do with your sense of smell and your sense of taste, respectively, are less common, but are often observed in people who are severely psychotic. And then there are delusions. Delusions are false beliefs that are nevertheless believed 100%. And you probably, in your abnormal psychology class or psychopathology class, have heard examples of different types of delusions, which include um, delusions of grandeur, which is the false belief that you have great power, or are related to someone with great power. Um, Delusions of persecution, which is the false belief that someone is out to get you or is trying to hurt you or plotting or scheming against you, and so on and so forth. Next are psychomotor anomalies. These are primarily observed in type 2 schizophrenia, associated with the so called negative symptoms of schizophrenia. Remember, when you are talking about psychology, when you use the words positive and negative, that doesn't mean good or bad. Positive usually means the presentation of something, something in excess, whereas negative means that something has been withdrawn, taken away, or something that is lacking. So, classic examples of that in behavioral psychology would be positive reinforcement, negative reinforcement, which doesn't have to do with how good they are, it has to do with the presentation or the removal of a stimulus. So, here, when we're talking about the negative symptoms of schizophrenia, we're talking about symptoms associated with a lack of something. So, in a lot of people with schizophrenia, one of the psychomotor anomalies they'll suffer from is a lack of movement. A lot of people will sometimes be very rigid, very stiff. Sometimes they can lie in a catatonic state for a very long period of time. And then also, there are profound deficits in behavior. Um, there's a lack of fluidity, there are often errors, there's a lack of coordination sometimes associated with schizophrenia. And often, too, there is a lack of insight. This is especially the case when someone is suffering from hallucinations and delusions, because, of course, their belief is that what they're experiencing is real, and yet the people around them are telling them that um, that what they're experiencing is not real. Interestingly, when someone has a delusion, they have to take it on faith that it's not true, even if they've been told that it's not true. For example, I once had a patient who believed that his son was Jesus Christ, and when I gently told him that this was impossible, he said he understood that it was a very illogical thing to believe, but he nevertheless could not stop believing it. So even though you could logically explain a delusion to someone, it doesn't necessarily mean that they'll stop believing it. The belief is very, very powerful, and it's very difficult to shake. In the DSM, for diagnosis, you are required to have two of these symptoms for 6 months or more in order to be diagnosed. If the symptoms last 1 month or less, that's called a brief psychotic disorder. If the symptoms last up to 6 months, that's called schizophreniform disorder. And if the symptoms last 6 months or more, that's called schizophrenia. Moving on to slide number 3. In the old DSM editions, you used to see these different types listed, and you can still hear these types mentioned by psychiatrists and psychologists sometimes. You might even refer to, a lot of patients might also refer to themselves as being one of these types: catatonic, paranoid, undifferentiated, disorganized, or residual. These types have largely been replaced in the DSM, and you'll see this little note down here at the bottom. The DSM-5 got rid of these subtypes because patients would often present with one type predominantly, but then change to another subtype shortly thereafter. So patients would not often stay in these states for very long, so they got rid of these types. But just be on the lookout, you'll still hear some people refer to these different types. And the most common one you'll hear is the paranoid schizophrenic, because a lot of people with schizophrenia understand what that means. They have some degree of insight about paranoid schizophrenia. These other categories are largely not going to be mentioned a lot. For example, it's very rare that you'll hear someone with catatonic type schizophrenia actually say they have catatonic type schizophrenia, because someone who's catatonic is usually not talking to you. Residual meant that someone was showing some residual signs of schizophrenia while not having a full-fledged psychotic break. And then there are phases of schizophrenia called the prodromal phase, which is the phase of schizophrenia just before when a person is not fully symptomatic, but they're starting to show some warning signs that they're about to be fully symptomatic. The active phase is when they're exhibiting the major symptoms of schizophrenia. And then there's that term again, residual, when they start going back to how they were before, and they're not as actively psychotic as they were before. The etiology or the cause of schizophrenia has been something studied very heavily. In fact, of all mental disorders, schizophrenia has probably studied the most out of all the different categories of disorders. It's the subject of untold numbers of thousands of dissertations and master's theses, including my own. I did my own master's project and doctoral dissertation on the subject of schizophrenia. Um, Schizophrenia has a very strong genetic loading. That is to say, the closer you are related to someone with schizophrenia, the higher the chances that you'll have schizophrenia. And this has been revealed in those famous studies in psychology called the twin studies, which show that the genetic effects of a particular disorder are very strong and actually increase with age. Another finding in people with schizophrenia is that they have enlarged ventricles. Ventricles are the tubes in the brain that carry blood and cerebral spinal fluid, and those are found to be unusually large. And you might say to yourself, well, wait a minute, if some of them are carrying good fluid in the brain, isn't that a good thing? Wouldn't that be to someone's advantage to have enlarged ventricles? Well, no, not necessarily, although, of course, we do need oxygen to get to the brain. When you have enlarged ventricles, what that means is that other brain tissue is being impinged upon by those enlarged ventricles. And when they grow larger, there's nowhere for the surrounding tissue to go, so it often dies as a result. So enlarged ventricles sounds like a good thing, but it's actually not a good thing. People with schizophrenia have smaller anterior hippocampi, which is, if you know about the hippocampus, that means that schizophrenia is going to affect memory, and it does. People with schizophrenia are notoriously prone to having memory problems. Not the kind of memory problems you see in Alzheimer's disease, usually memory problems associated with making mistakes and perseverating. Decreased prefrontal activity. This is something you also see in people with antisocial personality disorder, with attention deficit hyperactivity disorder, ADHD. And when this is present, when there's decreased prefrontal activity, it's often associated with the severity of the so-called negative symptoms of schizophrenia. And here's an example of these enlarged ventricles in slide number 5. Schizophrenia, these are MRI scans of a 28-year-old male, identical twin, showing the enlarged brain ventricles in the twin with schizophrenia. So even though these are twins, here's a case of one twin who did not get it and another one who did. And so this person on the right, these centrally located ventricles right here, are enlarged in the patient with schizophrenia. And this is the brother on the left-hand side. Several hypotheses have been offered as to what's causing schizophrenia. One famous one is the dopamine hypothesis, here just abbreviated DA. We do know that schizophrenia is very strongly associated with higher than normal levels of dopamine, or at least overreactive dopamine systems. So notice that doesn't necessarily mean that schizophrenia is caused by excessive dopamine. It could be that the dopaminergic systems are just overactive and very sensitive to dopamine, or overly sensitive to dopamine. Either way, it's associated with too much dopamine. And this hypothesis is supported by the effectiveness of a certain class of drugs, one of the oldest class of drugs in the treatment of mental illness, the so-called phenothiazine drugs, which block and bind to postsynaptic dopamine 2 or D2 receptors. So because these drugs work, and because they work on D2 receptors, and they help with mainly type 1 symptoms of schizophrenia, your hallucinations, your delusions, and your grossly disorganized speech and behavior, it suggests, at least on some level, that dopamine is involved. We also know that this dopamine hypothesis is supported by the fact that any drug that increases dopamine also causes an increase in psychosis. So we know, for example, that many stimulant drugs like cocaine cause a surge of dopamine, and people who are on cocaine for a long period of time face several problems, including high blood pressure and problem with your arteries um, and several other things, but they also are at increased risk for psychosis. The problem with just looking at schizophrenia as purely being about too much dopamine is that there's another drug that works called clozapine, which is part of this newer class of drug called the atypical antipsychotics, which doesn't block dopamine, but nevertheless it still works to fight against some of the symptoms of schizophrenia, both positive and negative. So, what is happening? That's the big question. Why do people still um, become schizophrenic, even though we have a pretty good idea that it's about dopamine, but that just tackling dopamine doesn't do everything? So that's led some people to develop what's called a modified dopamine hypothesis, which says that the positive symptoms of schizophrenia, so remember when we say positive symptoms, we're talking about symptoms that are excessive, excessive hallucinations, excessive delusions, excessively disorganized speech and behavior. This seems to be caused by excessive dopamine in the mesolimbic system. But the negative symptoms of schizophrenia, the symptoms that are associated with a lack of things like a lack of speaking, a lack of movement, a lack of social interaction, a lack of something that a lot of people with schizophrenia suffer from is they lack intonation in their voice. They don't modulate their voice very much. They tend to speak in a flat, soft, or robotic tone. This is caused by lower activity of the prefrontal cortex. There, has also been noted that there can be hypofunction of the glutamate neurons, which connect the four areas of malfunction in schizophrenia. This may be a cause as well, and this was the work of Bacchus and Kleinman in 1996, which has led some people to say that something else is going on that's not just purely these dopaminergic systems. And down here on the bottom, I do list what those four areas of dysfunction in schizophrenia are. They are the prefrontal cortex, the mesolimbic system, the striatum/nucleus accumbens, and the medial temporal lobe. Now, you may remember earlier in our course we talked about this structure, the nucleus accumbens, which is very strongly associated with addiction and with stress and fear. And it has a very prominent role as well in obsessive compulsive disorder. And for some people with schizophrenia who tend to make very repetitive mistakes, and they fail to learn from their mistakes, that's a hallmark feature in schizophrenia. Not talked about that much, but was the source of my dissertation. It is important to look at these other brain structures as well. Moving down now to slide number 8 is another hypothesis called the glutamate hypothesis. And this hypothesis says that schizophrenia is called by the hypoactivity. So not hypo, meaning less than or underneath. Hypoactivity of glutamate, which has the secondary effect of increasing dopamine. So you may have heard of something like this before when we talked about serotonin and norepinephrine. Remember how we said that serotonin works not because it works directly as kind of a happiness drug or chemical or neurotransmitter in the body, but because serotonin works to regulate the amount of norepinephrine we have. So you'll remember that when we were talking about depression. Well, glutamate kind of has that same kind of relationship with dopamine. The more glutamate we have, the more we can regulate the amount of dopamine that we have. So if we don't have a lot of glutamate, it's going to decrease the amount of dopamine that we have. So this hypothesis is basically saying when dopamine is not active, it's going to cause a decrease in dopamine. So it has the secondary effect of increasing dopamine. So when you increase that dopamine, you're going to get higher levels of schizophrenia. So this may have been worded incorrectly because that sounds a little bit confusing. The evidence for that, for the glutamate hypothesis, is that a drug called PCP, not used as much anymore, but was used, it goes by the street name angel dust, causes schizophrenia-like symptoms and blocks glutamate. Okay, skipping down to slide number 9. Which has to do with what's happening with schizophrenia as people have it and as they develop it. Well, there have been several studies that have looked at this very closely. One is that schizophrenia seems to be uh, at least somewhat related to when you were born. Um, an interesting series of studies when people were looking up what time of year are people with schizophrenia born, and they tend to be born more frequently during winter months. And so it was thought that schizophrenia could be associated with viral infection or exposure to some sort of illness or disease in utero, which can cause abnormal development, and that these kinds of effects can even last well through childhood and even into adolescence. So that's one possibility. The problem with that is that um, gestation lasts 9 months, and there are many critically important times during a child's development in which a virus could affect their development. So just because you're born during winter, which is a time of year when there are more viruses than warmer months of the year, that doesn't necessarily mean that that's when the virus is most likely to take effect. So it was an interesting finding, but I don't think it explains everything. There is more strongly, the suggestion that schizophrenia may be degenerative. Um, and the idea there is that once people have psychotic episodes, the enlarged ventricles get even larger. And of course, every single time someone has a psychotic episode, that means that it's likely that some brain tissue is going to die. So it's not going to be as severe as someone who has a concussion or someone who has a stroke or someone who has a seizure. But nevertheless, over the long course, the more psychotic episodes a person has, that is to say, the more times they are actively symptomatic, it suggests that the brain may become debilitated. Um, we do know, though, that these second generation of antipsychotic drugs, called the atypical antipsychotics, may stop some of this degeneration. One thing I would like you to know, however, is that schizophrenia is notoriously heterogeneous in its course and presentation. And so looking for one particular cause is probably not the way to go. We've been looking for kind of that magic bullet, that one model that's going to explain everything, or one hypothesis that's going to explain everything. And although there have been several compelling and good theories, no theory has necessarily won the day at the expense of all others. Treatment is also very complex with schizophrenia because, as you may have guessed, if you decrease the amount of dopamine that a person has, you may remember in taking another course that puts you at increased risk for Parkinson's disease. So that is the trade-off. When you have too much dopamine, it appears to cause psychosis. Too little dopamine is associated with movement disorders, tics, tremors, and in some cases, Parkinsonism or Parkinson's disease. Relapse is very common in schizophrenia. There's a 70% recurrence rate within 1 year without meds versus 30 to 40% for people who are on medication. So, as you can see, medication for people who have schizophrenia is really, really essential. This also may be a tough sell, even though we know that medications work very, very well. In some very traditional communities, you might find some resistance to medicating someone with schizophrenia because a lot of people who um, hear about schizophrenia, they seem sometimes to think that it could be a person is possessed by an evil spirit or a demon. And so it might make them more likely to seek out help from religious healers um, or traditional healers. But the best knowledge we have right now says that medication is definitely a first line treatment for people with schizophrenia. And the earlier the better. The earlier you get people on medications for schizophrenia, the better they're able to manage their symptoms. And it um, also predicts a better response down the road when a person continues to be medicated. All right, moving down to slide number 11. Now we're talking about the medications themselves. Um, Here are those old phenothiazine drugs that we were talking about, chlorpromazine. That's the generic name. The trade name is Thorazine, was invented in 1952. It started out as a phenothiazine class drug used as a sedative to calm people down. We talked about that, right? That's a big goal of a lot of people in psychiatry, is to calm people down. But then later as an antipsychotic, they kind of noticed on accident that people who took it tended to not just calm down, but their symptoms started to go away. And so it blocked these D2 receptors. and it's pretty effective at treating the positive symptoms of schizophrenia. We'll come back to these in the area of side effects. The next class of drugs were called the neuroleptics. These still are referred to as the first generation drug, even though the phenothiazines came earlier. These are still considered to be the first real generation of a class of drugs because there were so many in this category, whereas the phenothiazines were very few. The most famous of the neuroleptics, you'll also hear another name for neuroleptics. They're called the conventionals. The conventional neuroleptics, or just the conventionals, or just the neuroleptics, but they all refer to this main big first generation of drugs. Was called Haldol, and these drugs, the neuroleptics, were named because of the neurological side effects that they created. So, whenever we're talking about the treatment of schizophrenia, you always are talking about the side effects of the medications because they tend to be a lot more severe than the medications you take for anxiety and depression. So here are those side effects that are associated with the first generational antipsychotic drugs. All of them produce these kinds of side effects. First are called extrapyramidal. So it looks like I misspelled that here, so let me fix that even while I'm here. I put in an extra R in extrapyramidal, but it's extrapyramidal. And these are side effects that are associated with blocking dopamine that causes that Parkinsonism type movement. It also causes some dystonia, which is when dystonia just means that you're not showing as much rigidity in your muscular skeletal system, so you're not able to clench as strongly, you're not able to have good muscle tone, and you're kind of limp in your posture. It's also associated with muscle spasms, which are involuntary movements, and akaesthesia, which is doesn't sound like a very serious thing, but it's really awful. It's a tendency for the patient to have extreme restlessness. It's almost like if you've ever been tired but unable to sleep and you get restless legs, it can feel really tortuous when you have it. These are people who feel an extreme sense of restlessness, and it's very difficult to calm them down. Second are what are called the anticholinergic side effects. These are associated with dry mouth, blurry vision, constipation, sexual dysfunction, and sedation from the blockage of acetylcholine. So the anticholinergic side effects are so named because of the blocking of acetylcholine. And then the anti-adrenergic side effects, which include low blood pressure and dizziness from standing. Now, you may have heard of this condition before when someone stands up very quickly and then they feel very lightheaded. This is a condition called orthostatic hypotension, and sometimes it can be dangerous. Usually it just results in a person sometimes needing to lie down. But that is one of the side effects that can be really annoying if you've been sitting down and you suddenly stand up. Down here on the notes on the bottom, I wrote, extrapyramidal is part of the motor system that causes involuntary reflexes and movements. To distinguish it from the tracts of the motor cortex, which are associated with voluntary movements that then reach their targets by traveling through the pyramids of the medulla. So we say extrapyramidal, meaning outside of the pyramids of the medulla. That's where it gets its name. Going down here to slide number 13. Other side effects include TD, which stands for tardive, Tardive, dyskinesia, tardive dyskinesia, tardive meaning late, and that just means a late appearing involuntary movement disorder. So this happens if a person has been on this first generation class of drugs for a long, long period of time. And the downside is that even if you discontinue the medications, the side effects persist. So they do appear to be permanent. And then there are some also atypical side effects, which can include weight gain, agranulocytosis. This is more seen in the second generation drugs than the first generation drugs, but you still do see it. Lower seizure threshold, meaning that it doesn't take as much electrical stimulation to cause a seizure. And then something very dangerous called neuroleptic malignant syndrome, which must be treated very early or it could lead to death. Now, obviously, we've been through all of these crazy side effects, and you might be asking yourself, why in the world would someone even bother That's just a reminder as to how severe schizophrenia is and how awful it is to have it, that people are willing to put up with these kinds of side effects. By the way, there are some medications that you can take to manage the side effects of the drug that doesn't actually take away from the effectiveness of the drug, but it sometimes can be difficult to get people to take those drugs. All right, now the second generation antipsychotic drugs, also called the atypical antipsychotics, as opposed to the conventional neuroleptic drugs. These are drugs that work to block serotonin and less so dopamine. You might say, what in the world? Why would we want to block serotonin? That's the drug that's so good at regulating other neurotransmitters. Well, remember, serotonin doesn't do just one thing. Like everything else in the body, there are several roles that are played by several chemicals. And for some people, too much serotonin is associated with psychosis. Um, these drugs have a couple of benefits. Number one, they have far fewer side effects. Number two, and perhaps most importantly, is that whereas the older generation of drugs only worked well to treat the positive symptoms of schizophrenia, the second generation of drugs works really well to treat both the positive and the negative symptoms of schizophrenia. Examples of these include clozaril, Risperdal, Zyprexa, and Seroquel. Other side effects include sedation and weight gain, and the most dangerous side effect is agranulocytosis. This is a dangerous loss in one's white blood cell count, which requires constant monitoring to make sure that those cells don't drop to dangerous levels. Of course, you need your white blood cells for your immune system health. And agranulocytosis can happen with the first generation of drugs or the second generation of drugs, but like I said, they're more common in the second generation. Other issues with medication is that patients are typically going to see their effects, the beneficial effects, after 1 to 3 weeks. Antipsychotics do treat all forms of psychosis, um, even without proper diagnosis, so that's a good thing. Um, Medication or medical treatment for schizophrenia should last at least 1 year after symptoms remit. So it's kind of like with the coronavirus, they're saying, oh my goodness, look at how well everyone's doing. Everyone can come out, everything should be fine. But then you're hearing a lot of epidemiologists saying, no, 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 don't do that. Uh, we need to keep on doing these things even though everything looks okay. We still need to be taking these precautions. Same thing with schizophrenia. I should also add that that also is true for people with depression. It's very important to take the medication even if your depression has lifted to prevent relapse if the depressive episode was very severe. The most common cause of relapse in people with schizophrenia is medication noncompliance, which, as you might imagine, is a very huge issue. So, education about staying on the medication is very important. Of course, there are also other major social factors associated with schizophrenia, including loss of work, loss of income, homelessness. Poverty is very, very highly correlated with schizophrenia, and I can talk to you a little bit about that and some other sociocultural implications of schizophrenia if you'd like. But for now, we'll come to the end of this lecture on psychotic disorders.